Thank you for being here this morning. I'm sure a few folks will come in as they're getting their breakfast. But I want you to kind of think about as we go through the presentations, like what brought you here? Like what are the things that you're hoping to get out of this session? And so we're going to do a few different parts of the program. Matt Gardner is going to talk about the early results. He has a case series that he's presenting at different conferences, and he's going to go over his data. And they're going to be relatively quick talks to kind of get to the question and answer period. Professor Rommens is going to talk about the fragility fracture classification for the pelvis and its value in data, as well as kind of how it can dictate treatment or used to dictate treatment. And then we're going to go into some case examples. John Yingling is going to talk about a combined acetabular and ring case. Langdon's going to talk about a geriatric acetabular fracture, fix and replace. Samir is going to talk about using CurvaFix for posterior column and then indications in high energy patients. And then I'm going to talk about peri-implant fractures and removing and maneuvering around indwelling implants. So the learning outcomes are to list the unique aspects of CurvaFix, discuss the early patient results, list the value of the fragility fracture pelvic ring classification, and outcomes, recognize the indications, and then utilize the techniques. So how did it become part of my practice? One of the things to consider is I really started using it in more geriatric patients. And so these are some of the biomechanical results that the company looked at, comparing them to different cannulated screw sizes and kind of the summation. This was in a bone foam sawbone model, which is very consistent from a biomechanical standpoint to kind of look at general implant properties. It doesn't necessarily matter what medium you use if you're doing the same testing for everything. So it showed that it's as strong as the larger screws, but much less deformation or change in shape with loading to failure. And then this kind of surprised me is the pull-out strength. I would think with fewer threads it has less pull-out strength, but it actually had more than even the larger cannulated screws, the 7-3 screws, for cyclical loading. Then the reason why I used it for my first case was maneuverability. So you can see here, rather than kind of having to end in the pubic tubercle area, I was able to kind of get it down lower into almost to the ischial ramus, at least the initial part of it. So there's more available osseous pathways, especially in sacral dysmorphs, and this was one of my indications is peri-implant fractures in working around indwelling sacral implants, usually from previous lumbosacral fusions. And I also think one thing to consider is if you don't do these very regularly, and I'm not encouraging people who don't do pelvis fractures to CurvaFix allows me to start doing them. That's not my point. The point is that with using a flexible guide wire, just like you do for long bone nailing, and being able to maneuver the guide wire, it's harder to go, at least my experience is it's harder to go out of the cortex. So that's just something to consider. And so with that, we'll start with Matt and him going over his early results.
Thank you, Brett. We have a lot of great cases to get to today, so hopefully this won't take very long. So my name is Matt. I'm from Springfield, Illinois. Just going to go over my early results. I had my resident pull my data about a week ago. I've done over 50 of these. I think concentrating on the low energy patients is kind of what I want you to look at here. Really the goal for these older patients is to get them up and get them walking as soon as possible. So I think the most important data point here is how quickly can we get these patients up and walking. We fix hip fractures early because of this reason. But looking back on my practice, these patients with pelvic fractures are kind of forgotten. And really sending them to a nursing home and making them non-weight bearing and waiting for that bone to start healing is what I've done. So these patients are usually coming into the emergency room. I send them up to the floor, and I have the physical therapy team who I've talked to. They know what I'm trying to do to mobilize them. So the patient either can walk or can't walk, or they walk with an extreme amount of pain. So if they can walk, they don't need the surgery. So they're already up and mobilizing. If they can't walk or they're walking with a lot of pain, then I go and I have a conversation with them, tell them what I'm doing, talk to them about early results. And really what you can see here is time and hours with the low energy patients to first ambulation. My goal is to get them up and walking as soon as possible. So these patients are walking between 7 and in the worst case 144 hours. So that's within a week. And I think that's, talking to these patients has changed a lot of their lives, and they're able to get back to a normal baseline as quickly as possible. The high energy patients are also doing fairly well too, but really in my practice, this is really helping the low energy patients. So having said that, let's get to some cases.
Yeah, good morning. Thank you very much for giving me the opportunity to speak about the classification and recent literature. So we have observed that the fragility fractures of the pelvis have specific characteristics that are not comparable to the fractures due to high energy trauma. So they are always the result of a low energy trauma. We are confronted with weak cortical and very weak cancellous bone that gives specific fracture patterns. There are a number of bilateral lesions and also H-type sacral fractures. The bone fails between the intact ligaments, so that means that we are seeing a collapse of the pelvic ring between the ligaments instead of an explosion, which is the case in high energy trauma. And in some patients, we also observe an increasing instability over time. That means during conservative treatment, additional fractures occur and the instability of the pelvic ring increases. For us, these were reasons enough to look back at about 250 patients that were treated in our hospital in 5 years' time, and we have seen a basket of different fracture patterns. It's a whole spectrum of injuries, as we can see also in the high energy trauma. But we could classify them into different degrees of instability. And the first criterion for this new classification indeed is the degree of instability. The second criterion for the subtypes is the localization of the fracture in the posterior pelvic ring. And you see here the different types. The first type is the anterior and isolated lesion. The second type is the undisplaced posterior lesion. And the third and the fourth types are displaced lesions, be it unilateral or bilateral. And indeed, we see that in literature, since about 10 to 15 years, the number of publications that are focusing on fragility fractures of the pelvis are increasing rapidly. Looking at the recent literature now, I have here a publication of 2016 from Germany. You look at 93 patients that are treated conservatively, and the mean hospital stay of these patients was more than 15 days. Adverse events during hospital stay, 58%, and a 1-year mortality of 20%. So that sets the scene, I would say, and you can compare then the results of operative treatment with that data. Here you see a publication of Finland, which is more recent, from 2019, looking at or comparing the mortality of hip fractures with the mortality of conservatively treated pelvic ring fractures. 219 patients for the FFPs, a 30-day mortality of 7.3%, a 90-day mortality of 11.4%. There was an 8-fold 90-day mortality risk when compared to the general population, and there was no difference in 90-day mortality risk between the FFPs and the femoral neck fractures, which means that this is really a serious trauma that these patients have. When we look now at the operative treatment, here you see a publication of somewhat less than 400 patients, also from Germany, where they compare conservative treatment, percutaneous fixation, and open reduction and internal fixation. You see the adverse events are similar. There is no higher adverse event in the operatively treated patients, and even the mortality The hospital mortality in the percutaneous group was 0, which was significantly lower than the other groups. Another publication recently from 2013 here, where they compared cemented sacroiliac screw fixation with conservative therapy, and they looked at several patient outcome scores. And you see at 6 weeks, for the different scores, there is a significant difference between the conservative and the operative group. You see it for pain, for the Bartle index, for quality of life, and for mobility, which is very relevant, I would say, for these patients which profit from an early benefit. Also, in our hospital, we looked back at patients that were treated with a transsacral bar osteosynthesis, and these were 85 patients with a follow-up of 3 years. The mortality here was less than 10%, and you will remember the 20% of the conservatively treated group in the other publication. 85% of this patient lived at home after 3 years, and 82% walked with or without a walking aid. And looking back at 500 patients during 10 years of treatment in our hospital, we could find a significantly lower mortality after operative treatment in the FFP2, the non-displaced lesions, and also in the displaced FFP3 and 4 lesions. You see the Kaplan-Meier curves here on the left for FFP2 and FFP3 and 4 on the right. The classification and also the treatment algorithm that we follow was endorsed by another publication that came out last year from the Augsburg group, and they concluded the strict compliance to the presented treatment algorithm with an operative strategy starting from a complete sacral fracture, FFP2C, leads to a significantly lower mortality within 1 year in comparison to the conservatively treated patients. And the next sentence is also important. The worst outcome and the highest mortality was seen in patients who refused the recommendations of operative stabilization. So to conclude, we think that the classification provides a good framework for analysis of the loss of the pelvic stability. It's also a guide to surgical treatment, and we have seen that this surgical treatment reduces mortality. The stabilization provides early benefits within weeks for the quality of life, the functional status of the patient, and the mobility. And I think speaking the same language makes our clinical and scientific work easier. Thank you very much for your attention.
Thank you, Professor. I'm John Michael Yingling from University of Oklahoma. How CurvaFix has been implemented in our region, we'll indicate it for curvilinear corridors where straight screws may be unsafe for placement, or during acute pelvis and acetabulum fractures where a load-sharing implant or immediate weight bearing may be beneficial, considering ipsilateral lower extremity injuries that may do better if your weight bearing is tolerated, or for low energy fragility fractures of the pelvis, sacrum, or acetabulum, where we'd be mitigating some of those stasis issues, almost like a hip fracture corollary, preventing people from getting blood clots or pneumonia or ulcers. Here's one of the cases we selected was JM. He was an 80-year-old male who presented to our facility for a periprosthetic right acetabulum fracture around hemiarthroplasty. And about 6 weeks prior, the family thinks, or maybe even a little bit longer, he had sustained a low-energy pelvic ring injury and was treated non-operatively and had been unable to get out of bed. He's been essentially bedbound since then. He attempted to get up this time and fell, and that's how he injured his right side. Before his fragility fracture of the pelvis, he had been able to ambulate with a rolling walker around his house independently. Here's an AP radiograph of his pelvis that we obtained. You can see on the left side he's got some callus formation around a pelvic ring injury, and the right side an acetabulum fracture. Here's a, how do I get that thing? The CAT scan that was obtained, you can see on the left side, he's got in non-displaced impaction of his left-sided sacral ala and a pubic root fracture with some calcification there, and also this ischial ramus with the acetabulum fracture on the right. Some choice cuts of the acetabulum fracture, demonstrating more of an impacted, we eventually classified it as a associated both column acetabulum fracture and a Rommens 2B pelvic ring injury on his left side. So surgically, we elected to use a curved intramedullary implant for his left-sided posterior elements. Navigating around his prior, we believe he had a sacroplasty, wasn't able to recall when or why that occurred, and also this antegrade anterior column implant, and then applied lateral traction to his right side and placed a quadrilateral surface plate to prevent that femoral head from protruding, and then through his iliac tubercle down his gluteal pillar, used an intramedullary implant down his posterior column. One of the things that was interesting here is I think the plate, provided some sort of a blocking element, which made that passage of the wire a little bit easier and kind of prevented it from coming out the fracture, which can happen sometimes. Here's so the reason we chose this was to help navigate his curvilinear corridors and then allow this elderly patient who's been bedbound for some time and deconditioned to allow him to get up and start weight bearing, hopefully help with pain control and help him start moving and get back in shape. Here's our final fluoroscopic images showing our AP inlet and outlet of the implant. Trauma team actually got a post-operative CT scan, which was serendipitous for us. It allows us to kind of nerd out and see how our intraosseous placement of our curved implants and following it down the posterior column there, as well as our anterior column, ensuring a safe passage here. So we'll thank them for that. These are just the coronal and sagittal reconstructions we can see through. So, sorry, I didn't notice the volume there. This is the patient. This is about between the 2 and 4 week period. The therapist was able to take a video and send it to us, but he was weight bearing immediately after surgery, albeit slowly, but was able to put weight on it with very little pain. And then at the 6 week visit, he's able to ambulate 100 feet with the therapist and is very comfortable. He's just still a little deconditioned from his time being down. But these are the radiographs from his 6 week visit that show no real change in the implant position and no real change in his resting deformity and some signs of interval healing. Thank you.
Hey, good morning. I'm Langdon Hartsock from Charleston, South Carolina. And I'm just going to show you a couple of cases that we've done. So I have 2 cases to show you. We've used it in revision arthroplasty cases around the hip when we need some column support. So this first patient, 65 years old, she's had bilateral total hips done elsewhere. She presented in an outside institution with hip pain for about 4 months with difficulty ambulating. She actually had, this is a revision on the left, so she had revisions on both, but she'd had recurrent dislocations previously. So she's got a dislocated hip with a periprosthetic T-type acetabular fracture and a subacute sacral fracture. So we took her to the OR and revised her. So we took the acetabular component out and used a posterior plate to get the posterior column reduced, and then placed the first implant we placed was the anterior column CurvaFix, and then just like the case you just saw, started at the iliac wing and can place this incredibly long intramedullary flexible screw type device from the iliac crest all the way down through the posterior column as some additional support along with the plate, and then cemented in a new acetabular cup with some screws that go through all that stuff. And she's actually done remarkably well. She was touchdown weight bearing immediately post-op. Sent home post-op day number 2. We saw her back a few months ago, and she's ambulating with a walker. So I think the advantage here was we were able to get immediate column support to park this acetabular component on and get some stability to put a new acetabulum in there. When you sort of look back at this initial x-ray and see the displaced acetabular fracture, this periprosthetic acetabular fracture, and basically the femoral head's articulating with the raw fracture surface there and the cup's loose. And so we were able to get that reduced, get some column support, and put in a new stable cup. And she's done fine. She's actually done quite well. The second one's a little more dramatic. She was 80-year-old woman, or is an 80-year-old woman, came in after ground level fall, presented outside an institution, hypotensive with left hip pain. She has some underlying dementia. She presented with this left periprosthetic acetabular fracture with complete dislodgement and medial displacement of her acetabular component into the pelvis. And she had iliopsoas hematoma, so she was resuscitated and stabilized, and trying to figure out what to do for this. Pretty challenging. So she actually, we actually got the transplant surgeons to help us, and that's what we found at our institution. The transplant surgeons are actually much more comfortable operating in the retroperitoneum than the general surgeons. And so she had a perirectus approach, and we were able to retrieve that displaced acetabular component. Was up underneath the vessels. And so he got that out for us. And then we went back, took the femoral head off the component, placed the anterior column screw, and this guide wire that's used for this device, I think it's just, I don't know what it is, but it's incredible. We were able to pass it across this huge gap and into the pubic ramus and the pubic parasymphyseal area. Put a CurvaFix screw down that, and then actually went intrapelvic on the pelvic brim and placed the posterior column screw. So that gave us our column support across what was a segmental defect of the acetabulum, and then cemented in a acetabular component. And she initially did well. She actually dislodged her acetabular component, had to have another surgery a few months later to put in a new acetabular component with some screws, which I think if I had to do it over again, that's what I would have done the first time, is instead of putting in a metal cemented type cup, is put in a standard cup that has lots of holes that you can just drill the screws right into the cement. And she's actually supposed to come see me in a couple of weeks, but she's been doing well. She's at a assisted living facility a few hundred miles from us, but she's doing fine. So I think the advantage, again, is that you get immediate column support. You can immediately weight bear these patients. You can get a stable acetabulum to put a new acetabular component in. It's been very gratifying to do. Thank you very much.
40-year-old female, status post-MBC versus a pedestrian polytrauma patient. You can't make this stuff up. So she has an existing left BKA that was crushed in the car accident. So she can't walk on her left side because she has no left leg anymore. C-section ×2, and this is important. She is a single parent who is the sole caretaker for a child with needs. Really complex social situation. I bring this case up because this was the first case that I did using CurvaFix. I sort of wrestled with, why did I use it? I can put screws in anything. I've been doing this for a while, blah, blah, blah. And so right proximal humerus fracture, multiple rib fractures, left proximal humerus fracture, left distal humerus fracture, interarticular comedy, standard polytrauma patient, and then a pelvic ring injury, which I don't know if the CT is going to play, but maybe it will, maybe it won't, nope. But she's got a right sacral fracture, a right superior pubic root with a parasymphyseal injury, so segmental. She's got the proximal humeri on both sides. She's got the interarticular distal humerus. She's got the flail test, and she's got the BKA without a prosthesis for her left lower extremity. The other scenario, the other issue was that she had to be early weight bearing. She won't get a new prosthesis for her left lower extremity for 4 weeks. We had some insurance stuff, and our prosthetic people came in, and they were going to make her a temporary one, but it was not going to be overnight is the problem. And so she, because of her social situation and her issues at home, one of the things that came up was the ability to have to weight bear through the right lower extremity, given that we were going to let her weight bear through the uppers, but how is she going to get around if she can't really mobilize on the right? And historically, I have not let patients weight bear immediately with traditional fixation of the pelvic ring. So now I've got this patient who I could put screws in, traditional screws, but she'll be toe touch or non-weight bearing because she can't be toe touch because she has no toes on the other side. And the other injuries that she has. So, of course, the first thing that gets done is the general surgeons fix her chest. Like, that's the first priority, but that gets done first. And then we sort of start working on her, get her upper extremities done. And so, like I said, for me, I in talking to my health system, trying to get these screws in, this to me was a very reasonable, very rational decision to put an implant in that would allow me to allow her to weight bear immediately on that side. And so the screw in the back, I know you guys have seen sort of pictures of this, so I'm not going to belabor this. You can see the tunnels, you can get the wire around the tunnels, you can direct it. So I got a transiliac screw all the way across, and then it came to her anterior column. Now this was, I said before, a superior pubic root with a parasymphyseal. So docking the screw in the symphysis, or on the injury side, may not provide enough stability. So the idea that I had here was, and you may have seen some of these x-rays already, is to take that guide wire and send it all the way across and dock the screw in the uninjured side, so at least had some stability of the parasymphyseal region, allowing me to have her weight bear early. The other interesting thing here is, for those who are non-believers, this is a 9.5 millimeter screw that's about to go in, not even a 7.5. So this is the large diameter screw that went into the anterior column, and I have CTs to show that it's contained all the way through. I allowed her to be immediate weight bearing post-operatively on that right leg while she was waiting for her left lower extremity prosthesis. This is her x-ray at 6 weeks. She's been full weight bearing, and I actually haven't seen her since her 6-week mark. So I have no idea what she's doing, but she hasn't come back, and she was able to go home right away. She was able to take care of a child. She went back to work a week after we discharged her. 48-year-old male, stas post-fall. He's a transfer from an outside hospital. He's a BMI of 52. I'm not sure what he was doing up 18 feet, but he's got BMI of 52. Past medical history is a little bit complicated. COPD, hypertension, AFib, and heart failure with an ejection fraction of 50%, which I thought was a good number, but I guess not. And so you can see his wonderful x-rays that we got that are not terribly helpful because of his body habitus and our x-ray technicians. But you can see the anterior column injury or the superior pubic root on the right. He's got a superior pubic root on the left that you can sort of make out on this image here. And he's got a right-sided sacral fracture, which I don't think the CT is going to play, but so he's got a posterior ring injury, bilateral anterior ring injury, and oh, it is going to play. There we go. So we've got a few different options for him. He's unable to mobilize. He's got some other non-surgical but medical issues as well. So we want to do upper sacral segment fixation in the back, and then I was trying to figure out, do I put an X-fix in the front, do I put an in-fix in the front, or do I do bilateral anterior column screws? He is not a kind of a human being that can be non-weight bearing for 6 weeks or 8 weeks waiting for his anterior column and his posterior segment to heal. And so, and you can see putting an X-fix on him with his pannus may not be the best idea since his pannus is outside the CT scanner or the CT image. And then the idea of an in-fix, I've done that before. I always worry about perforation of the abdomen in people who are this big, just avoiding kind of getting into the abdominal contents, which is a reported complication in this patient population. And so for him, we did bilateral anterior column screws and that posterior transiliac screw. I made him weight bearing immediately post-operatively, and this is him at 3 months. He's weight bearing fully. He's got no assisted devices. He hasn't done any PT, shockingly. His pain is 2 out of 10, but he's just taking over-the-counter medications. So again, one of these situations where I didn't think an external fixator was a great idea, and getting him weight bearing was critical, especially with his body habitus. So those are the 2 high energy cases I'm going to share, and then I have an acetabular fracture that was treated with CurvaFix. This is a 90-year-old male, stas post-fall, transferred again from an outside hospital. He's been unable to bear weight on his right leg since his injury, and initially they were treating him like a femoral neck until they got a CAT scan. I'll show you the scan in a second. He's a community ambulator with a cane. He lives in senior living but lives independently, and he's been at the outside hospital for 4 days, unable to bear weight. The other reason he got transferred was he had a C2 fracture, which ultimately our neurosurgeon said was non-operative. So he's a non-operative C2 fracture, 4 days bedbound. PT has attempted to get him out, but they haven't. So then he got transferred to our hospital, where you'll see the CT hopefully play in a second. It's very minimally displaced, but he's been unable to bear weight for 4 more days in our hospital with 3 attempted sessions of physical therapy. So this guy's sort of stuck. He's got ambulatory dysfunction. Sniffs are really not, he can't do anything because he can't bear weight, so they're having trouble sort of placing him. And so we talked about, all right, well, if we percutaneously fix his columns, I'll let him weight bear immediately and he can maybe go somewhere. The only issue here, and I don't have a problem putting in supine posterior column screws. I think it's a pain in the butt a little bit because you have to lift the leg up and put the screw in. So it's easier to go prone, which I don't have a problem doing either, except in his case, neurosurgery said you could go prone, but then you have to neuromonitor, which that just adds a layer of complexity that I'm not interested in, right? So like, I don't want to have to deal with neuromonitoring and whatnot. So, but I also didn't want to, I wanted to put a posterior column screw in him so I can mobilize him quickly. So put the anterior column screw in, and then instead of having to go prone, went supine through the gluteus medius pillar, and you saw Langdon's x-rays as well that showed this, but you're able to, which is challenging to do with a straight screw, I think, go from the gluteus medius pillar down the posterior column into the distal end of the fracture site. And so you can weave it around the articular surface, as you can see, and then position your screw. He's immediate weight-bearing post-operatively, and he was discharged back to his senior assisted living facility, so what is his home, on post-operative day 2. He returned to clinic at 8 weeks, home, walking with a cane, also 2 out of 10 pain, mostly in his medial knee, and he's got no hip pain that he complains of. Thank you.
All right, last case presentation, then we'll have an opportunity for you guys to ask questions. So this is a 69-year-old who had right groin pain with weight bearing, had occasional use of an assisted device prior to basically a fall into a door side frame at a store, like a automatic door, like hit her, she hit the other side. She has multiple medical issues, as you can see. She presents to the ER, had pain secondary to her rami fractures, but really no pain posteriorly, and you can see that she's had a previous lumbosacral fusion. She then presents to clinic 3 weeks later and is having increasing pain. You can see that she's actually starting to show some callus anteriorly, and we're getting close a little bit on time, but to be respectful of your time, there's callus forming anteriorly, and she has basically a peri-implant fracture around her lumbosacral fixation. And so she's obviously trying to heal it at 3 weeks, but her pain's actually increasing. And she said, I have a 90-year-old mother, and my 90-year-old mother can get around better than I can. She's basically in a wheelchair. And so she doesn't really have any rotational deformity. It's really just the Rommens type 2 that's really not displaced at all. We tried another month of non-operative treatment. 5 months later, she comes back, and you can see that she has basically hypertrophic delayed or non-unions of her rami fractures anteriorly. She's using a walker and a wheelchair. Right anterior pain is greater than posterior pain, and she is tender over her sacrum. So she really wants something done. She has significant risk factors for delayed or non-unions, including she's had her lumbosacral fusion, so she's got an increased rigidity posteriorly, which she's kind of more going to the insufficiency fracture mode back there for that particular fracture. She's also had a gastric bypass, so I don't know if you take care of these patients, but the risk of like a distal radius fracture within 4 years is 4 times higher than the normal population. So they have a higher risk of osteoporosis. She's also had a family history. So these are her problems that she has. And I think at least I see one of these lumbosacral kind of sacral insufficiency fractures becoming more frequently, probably like 1 every other month. And so I think this is a potential kind of landslide of patients as they get older and their bone gets weaker after their lumbosacral fusion in their 40s and 50s. So this is intra-op. She had to delay because she had some heart issues, so we get to her at around 6 months. This is just showing that you can redirect if you don't get it the first time. So this is the first attempt trying to get around. And I wanted to get fixation into the first sacral segment because that's where her fracture was, around her hardware. And so this is just steering around the indwelling implants. Couldn't get the reamer pass with the first pass, so did a second attempt and just changed the trajectory some, and was able to get it into the other side. Professor Rommens showed that, increasing rigidity to the opposite side, and that's what a lot of us do for high energy patients too, increases fixation and stability. And so that was the goal, rather than, she actually had like a U-shaped fracture around her implants. So I wanted to go to the other side. And so this is getting the implant in across and transsacral, transiliac, and then did a retrograde ramus screw because the 9.5 was too big for her corridor. So like the rest of the cases, she was weight bearing as tolerated immediately. She did end up going to get evaluated for bone health, worked with physical therapy. And she, at 5 weeks, she had an episode related to her blood pressure, got hypotensive and fell. She didn't have any increasing pain in her pelvis. 6 weeks, she's starting to show increasing bridging callus on her delayed hypertrophic unions. She comes back still using a walker, but she didn't really have any changes in her pelvis from this new fall. And then I just saw her about a month ago. She's 12 months out. She's now back to using a walker and actually started having junctional level radiculopathy from her previous spine surgery. And so she's in the process of getting that worked out. She definitely said it's different from her previous pelvic pain and more similar to her pain that she had prior to her back surgery. So in summary, we've heard from different cases presented. Not all geriatric pelvis fractures should be treated non-operatively. And so if you do these in your practice, or I think all of us probably see these patients, you have to figure out which ones will benefit for surgery. And it's obvious when it's obvious, but the gray zone is the hard one. And so there's a bunch of research trying to get done to try to help people delineate the gray zone, because those are the patients that may kind of hang out in the sniff for 2 months and never show up until a year later, and they're totally deconditioned. Or, they show up. I have a lady that showed up 2 years later, and it is a significant quality of life problem. Fixation, and I think most of us who fix these feel like they get improved pain and improved function afterwards. And then I think particularly in these peri-implant cases, for me, maneuverability, at least for what I wanted to do in this case, made it possible. So with that, we can take some questions. There's a lot of y'all out there, so if nobody has a question, I'll be disappointed in all of you. You in the back? So I have, but I'll let other people talk about. So how easy is it to get out? So the question was, has anybody taken one out?
I have. I had to take a screw out. I put one in intraop, and then I wasn't happy with its position, so I removed it and put a new one. in. I have not had to do that yet.
No, Matt?
I've taken one out intraoperatively, but not.
Okay, so I'm the only one. So I had one, sorry, John, go ahead.
You had to retrieve one when we used it.
Yeah, you got to use the mic. Sorry.
Yes, we've had to remove one postoperatively. I think it was about somewhere between the 6 week and 3 month time period.
And so how, you removed it or your partner
No,
removed it? Okay.
postoperative, yeah.
I removed one at about a year, and a really recalcitrant sacral non-union around with a really bad osteoporotic patient. It actually broke, and we're in the process of writing it up. I had another device in there, a screw that broke as well. And so she had indwelling sacral hardware, but even though it was broken, the cables inside, like I was able to pull it back to where it engaged the sacral hardware that was in there from her back surgery, and then I couldn't get it past it, so I had to drive it out the other side. But there is removal instrumentation, even stuff that will core out over the bone that, if you ever take out screws, you get bony overgrowth, like there's a device that helps kind of improve the ability to get access to it.
Do you ever go in, out, in?
For the sacrum?
In general, with this screws like?
But you're talking about posterior?
Yeah, to see or even anterior column. Have you ever tried to go out and
So the question is, has anybody tried to go in, out, in, just to, because the anatomy doesn't allow, or? Okay. Oh, for size, okay.
I've not had an issue with the 7.5 screws going in, out, in, and even before the 7.5 screws were available, I didn't really have an issue with the 9.5 screws in the right patient. You have to be thoughtful about the 9.5 screws in the anterior column if you're going to use those in patients, because smaller patients I don't think will accept that, but not with the 7.5 millimeter screws. No.
Matt, or Langdon, anybody have any?
I have no problem.
Yeah, I've not ever intentionally done that. Okay, I'll ask questions.
So, well, one thing about taking
No, you don't
them
get to
out.
ask one. I'm just kidding.
One
Go
thing
ahead.
about taking.
hardware removal case? Have you had cases where this hardware is broken?
I've only had one.
Yeah, so I had one putting it in. The handle has a torque limiter on it, and if you don't use the torque limiter, you can break these in half. If you put too much torque, so it happens when you've got your curve is too steep, and somebody with a really good bone. And so I didn't listen to my rep, and I said, if I just get 2 more turns on this, I think I can get around the corner. And so what happened was it sheared in half, and I went retrograde to push it back out. And so I threaded my reamer over the guide wire sticking out the end of the nail, and started pushing it backwards. And then what happened was the guide wire bent around the nail. And so the threads on the nail are not very much wider than the links. And so trying to get it out from the other side, at one point I got frustrated. I grabbed a hold of the wire and pulled the wire out, and the whole implant came with it. So once you get it unlocked, it's that 3D structure that gives it the stiffness. It's not the threads. The threads don't really matter. They're not really that much wider than the links. So if you can get it unlocked, a lot of times, and grab a hold of it, you can pull it almost all the way out in most cases. So I've done that in cadavers a couple of times when I've had one deep in a patient before they had the new extraction devices. If you can get it to back out just a little bit and grab a hold of it, if it's unlocked, it'll usually come out. So
You haven't had any of them breaking up.
the one that I put in without using the torque limiting handle.
Doing it correctly, I have not had any fail or break. To answer your question,
Follow the.
if you follow the rules, yeah, I have not had any failures. And I weight bear all my patients immediately post-operatively with this, unless there's another lower extremity injury that would conflict with that. But if they can weight bear on their pelvis, I let them weight bear immediately.
Yeah.
Yes.
I think I heard one person say there was a cemented screw secret there.
That may have been in when Professor Rommens was talking about the paper. That's just pelvic fractures in general, but I don't know if you want to. Is that what you're talking about, maybe?
Yeah, but you haven't used it with the CurvaFix.
Has anybody put cement through the cannulation? I've not. No. It may be worth talking, Langdon, talk about your sequence again about when you cemented. You had all the devices in, and then you put the cement in, and then the cup.
Yeah. So.
You just push. Yeah, there's a little button.
Yeah. So the devices. In those 2 cases, the devices go in, and in those 2 patients, both of them had just absolutely massive metallosis, and so there was an enormous debridement that had to happen, and basically there was no bone left for fixation of the cup into native bone. So we put in the cement, and in the first case I did, DePuy makes a cemented metal cup, but it has no screw holes. And she did fine for a few months, and then that came loose, and so we went back and revised it to a standard press fit type cup with screw holes, and so we had to put new cement in. The cement interdigitates to the press fit cup, and put some screws in the cement, and that was good. So I suppose if you had a situation where you had relatively normal anatomy and you're just getting the columns and you've got bone there, you can park your acetabulum on. You could put a regular press fit cup and screws. But in those two patients, they had, there was no bone left. And that was where I think the CurvaFix was a huge advantage, because we got column support instantly, and then we just cemented in a cup.
We've got about a few minutes left. Any other questions? Dave?
Relative or absolute contraindications?
So the question is, any relative or absolute contraindications besides not following the rep's directions? Matt just pointed out.
Yeah.
Anybody have any absolute or relative contraindications?
I can't think of any.
Did you have anything in mind, Dave? Or
No, I just particular patterns or.
okay, Samir.
So if you're trying, the screw won't give you compression. So if you are trying to reduce an SI joint or compress a fracture, the screw is not built to compress. So you would need to provide compression before you put a CurvaFix in. So for instance, if you have an SI joint disruption that you're trying to reduce with a cannulated screw, you can put a screw in, say, S2, get your reduction with that screw, and then add your additional fixation with the CurvaFix if you want to go transiliac or something like that. But that's where I think that's the only sort of issue that I see, is if you're trying to get compression with the screw. It's not a partially threaded screw that'll squeeze, or a fully threaded that you can lag by technique.
Yeah, that's a great point.
Soft tissue issues associated with the implantation, or a few of the images look like they were maybe a little proud. And,
So when I first started doing this, the measuring was a little bit finicky, and so I had one that I thought was extremely proud, maybe a little bit more than that. It's about a centimeter or two. I think on the anterior column sometimes it's difficult
Yeah,
to tell, because
anterior
one side of the device is on the bone, the other side looks like it's way off of the bone. But early on, so the one I think it was proud about a centimeter and a half, and I was convinced that the patient was going to come in and complain, and they didn't feel it. I think it was an S1 screw, so she didn't complain. There's enough soft tissue there that I don't think it's an issue. The next case, I buried it, and I think if you ever have to extract a buried one of these, it would be difficult. They have new instrumentation now to do it, so that would help. But having it a little bit proud, you want to put it down to where the edge of the device is hitting the bone, and I haven't had anyone complain, even when it's too proud.
There is a countersink, so you can countersink the screw if you want, or partially countersink it, so you're not burying the entire head. So you can, if you're worried about soft tissue envelope, there is a way to get the head to be more flush.
John, do you have any contraindications or have any soft tissue issues?
No, not
Yeah.
other than what's mentioned.
Yeah, I think for the 9.5, or for the larger one, the cannulation system's a little bit bigger, so you have to get used to that. It's different than using like a regular cannulated screw. So if once you get past that, like the system allows for, after the initial soft tissue dissection, that it keeps it within it pretty much for the most part, and so there's less risk of soft tissue damage as you keep moving forward with the case.
Britt?
Yes. Sorry, one last question.
In really soft bone, have you had any issues with, as you're tightening and feeding that screw in, that it straightens out, and cuts through the neural foramina, outside the cortex or something like that? Is it flexible enough to really wind around, or have you seen that kind of straighten and start pushing into the major bone?
I have not seen it straighten.
As long as you follow the guide wire, I have not seen it take a different path than the guide wire's path.
Langdon, any?
No.
John?
I've got one patient, we used an antegrade anterior column screw that had a very comminuted ramus fracture that the screw is now extra osseous. It's not within the corridor on post-op. Doesn't bother him clinically, but it's definitely a scary x-ray. I don't know if that, within surgery, we have all the fluoroscopic images shown it was intraosseous at the time of surgery. And I think there were some splits within the ramus or comminution because of his poor bone quality where it may have escaped over the time of him ambulating. But other than that, no.
Yeah, I've not had them any straighten out or look like they straighten out post-op or intra-op. So it has followed, same like what the rest of them said, it follows the guide wire. But well, thank you for the questions. basically, we got some early data and saw Professor Rommens went over just fragility, fracture of the pelvis in general, and how the classification, I think, if like anything, if you're using common language, it can help kind of move the ball forward. And so that's one of the things that we can think about is using the specific classification for geriatric pelvic fractures. I think it does have unique capabilities as far as maneuvering around implants. This is a different patient to the point of the compression, like I put this in by technique compression, so then use the CurvaFix as a reinforcement around the hardware, sacral hardware. We went over some case examples and kind of showed kind of options as far as if you're having issues getting straight implants in, or if you're trying to get more 3-point fixation with more rigidity. But thanks for your attention and spending your breakfast with us. So we're happy to answer any questions afterwards, and have a great rest of your meeting.